In this video, we shall have a very brief discussion on the management of ischemic heart disease, which includes angina and myocardial infarction. Let us follow the events in a patient. Let us name that patient Shashi. So every day, this guy Shashi needs to climb 3 flights of stairs to reach his office. And lately, he has begun experiencing some vague chest pain while climbing the 3rd flight of steps. But the chest discomfort quickly disappears once he settles down in front of his laptop in his office cabin. But a pesky colleague of his persuades him to fix an appointment with a cardiologist, and he reluctantly agrees. The cardiologist takes a detailed history and finds out multiple risk factors for ischemic heart disease. So, with a high index of suspicion, the cardiologist decides to test Shashi. So he decides to give Shashi a stress test. He puts Shashi on a treadmill and, under a controlled environment, forces Shashi to exercise. There are certain standardized protocols for this, and on the basis of the outcome of the test, stable ischemic heart disease may be diagnosed. Now, if a diagnosis of stable ischemic heart disease is made, then Shashi needs to be started on treatment immediately. Now, what is stable ischemic heart disease? This can mean either stable angina or low risk unstable angina. The management of stable ischemic heart disease includes general measures, specific measures, and emergency measures. The general measures. This will include the administration of low-dose aspirin, which could range from 75 to 162 milligrams daily. This has to be given to the patient lifelong. In addition to this, the patient should institute lifestyle modifications, diet and exercise, together with the management of comorbidities that can increase the risk of ischemic heart disease, like dyslipidemia, hypertension, diabetes, and so on. So these are the general measures that the patient needs to be started on. In addition to this, the patient needs to be started on specific measures that need to be taken on a daily basis, irrespective of whether acute chest pain is present or not. These drugs will include beta blockers like propranolol. Beta blockers reduce the number and severity of acute attacks in future, and it is the only class of drug where there is definite evidence that shows a reduction in mortality. Other options include calcium channel blockers, not all of them, only verapamil and diltiazem. They do reduce the number of attacks in future, but there is no evidence that supports the fact that it reduces mortality. Nitrates, the long-acting nitrates like isosorbide mononitrate, modified release isosorbide dinitrate, and modified release nitroglycerin. These drugs reduce the number of attacks, but they definitely do not reduce mortality when used alone. In fact, they can produce more endothelial dysfunction when used alone. There are certain other so-called newer drugs which are used in angina. These include ranolazine, ivabradine, nicorandil, and trimetazidine. So these are the so-called anti-anginal drugs. They are the specific measures that we use for any patient with stable ischemic heart disease long term to reduce the number and frequency of attacks in future. Yeah, so general measures are there, specific measures are there, and thirdly, emergency measures. Now, if our patient Shashi follows our general measures and specific measures, then we can expect that the number and severity of attacks of acute angina in future will be very much reduced. However, if unfortunately, in spite of all these efforts, in future he suffers from an acute attack of chest pain, angina pectoris, then we must offer this patient rapid acting nitrates. These are not drugs which should be taken every day, but should be carried with the patient at all times. And if at all an attack of angina occurs, then the patient may take the tablet only when such an attack appears. So rapid acting nitrate, like immediate release nitroglycerin, classically administered as a sublingual tablet or a sublingual spray, may be used as an emergency measure only when there is acute chest pain. Thus, to summarize the management of stable ischemic heart disease, we have general measures, specific measures, and emergency measures. The anti-anginal drugs include low-dose aspirin plus the drugs used in the specific measures and the drugs used for emergency measures. Now, if to Shashi's misfortune, he does not do lifestyle modification or he meets a cardiologist and does not get appropriate treatment, then he is at risk of progressing from stable ischemic heart disease to acute coronary syndrome. Acute coronary syndrome may mean high risk unstable angina, non-ST elevation, myocardial infarction, or ST elevation, myocardial infarction. The drugs used in these three situations are the drugs used for the management of myocardial infarction. So let us say that our patient Shashi from the previous discussions suffers from an acute attack of angina. Now we have already given him the rapid acting nitrates and we have instructed Shashi to take this tablet if he suffers from an acute attack. So being a compliant patient, Shashi immediately places a sublingual nitroglycerin tablet below the tongue. He spits out the tablet after 5 minutes but finds no relief. In fact, he feels worse pain. He tries one more tablet and he does this 3 times across a period of 15 minutes, but he has no relief, and by now he is already on his way to the hospital. And once in the hospital, in the emergency department, he is correctly diagnosed with an acute coronary syndrome. And as we discussed earlier, an ACS may mean a high risk unstable angina, non-ST elevation MI, or an ST elevation MI. Immediately, he should be given low dose aspirin. Now, he should be given the upper limit of low dose aspirin, which is 325 milligrams stat orally. Then we have to look for clinical signs and establish whether the patient is in acute failure or not, acute heart failure or not. If the patient is indeed in acute heart failure, rapid acting nitrates is a good choice to give. Now in this case, Shashi has already taken 3 tablets of nitroglycerin on the way to the hospital. In addition to this, we may start IV nitroglycerin as an infusion once he reaches the ED. Now, if the patient is in failure, we can give rapid acting nitrates, but we should avoid drugs like beta blockers and calcium channel blockers. But if the patient is not in failure, we can definitely give beta blockers and calcium channel blockers. Now, in spite of giving these drugs, if the patient is still in pain, many physicians tend to prescribe morphine. The role of morphine in acute coronary syndrome is controversial and the matter is yet to be settled. At present, morphine is widely used in spite of lack of evidence supporting its use in the treatment of acute coronary syndrome. Now, while all this is being done, the diagnosis will be narrowed down to either non-ST elevation MI or ST elevation MI. Yeah. So, if the patient is diagnosed with a non-ST elevation acute coronary syndrome, which could mean a high risk unstable angina or non-ST elevation MI. If the patient is diagnosed with that, then two strategies are possible. Number one, an ischemia guided strategy. So if the patient is suitable for this strategy, then we simply give the patient dual antiplatelet therapy plus anticoagulation. But if the patient is not suitable for this, then we have to go for early invasive strategy, whereby we give the patient dual antiplatelet therapy plus anticoagulation plus an invasive procedure. Typically, this is done in the cath lab, and what we do is we either do percutaneous coronary intervention with stenting done in the cath lab, or we will have to take the patient to the theatre and do a coronary artery bypass graft. Following this, we will have to continue dual antiplatelet therapy with anticoagulation at some point in time. Now, if the patient is having an ST elevation myocardial infarction, again, we need to start the patient immediately on dual antiplatelet therapy and anticoagulation, and then we need to ask ourselves a question. Is this patient in a PCI capable hospital? If the answer is yes, do PCI as soon as possible, within 90 minutes. If the answer to this question is no, then we have to ask the next question. Can you make sure that the patient is sent to a PCI capable hospital within 120 minutes? If the answer is yes, refer this patient on an emergency basis and hope for the best. If the answer is clearly no, then there's no point in referring this patient. We have to immediately offer this patient thrombolysis, otherwise called fibrinolysis. Dual antiplatelet therapy with anticoagulation can be continued later. Now, if this patient survives the myocardial infarction, then we shift the patient from the ICU to the ward. Hopefully the patient survives and is ready for discharge. And once the patient is discharged, we should treat this patient as a case of stable ischemic heart disease moving forward. That means the patient should be offered the general measures, the specific measures, and emergency measures that we described earlier. So that concludes the management of angina and the management of myocardial infarction.